All right, welcome. This is the TBI Masterclass, specifically how to litigate brain injury cases. And our goal is to provide value to you throughout this masterclass by providing insights about how we are able to build up these cases and how we believe even the most mild of concussive cases can be potential 7- and 8-figure cases. So we're going to start off talking a little bit about our law firm. Nares Law Group was created at its inception to be a brain injury law firm that focused principally on changing the world by advocating for brain injury survivors. We believe in something called value beyond limits, which means this. We believe in a hopeful future. Life is short but precious. And for any person suffering from a serious brain injury, we have a moral, ethical, and just imperative to give them access to a life they cannot otherwise live. Policy limits are never a barrier, never. The reason this came about is these are unique cases that when you give a settlement check, the client doesn't want it because to them, it means the end of guidance, support, and advocacy for them. They continue to have symptoms associated with brain injury for the rest of their life because we're going to talk about how it's a permanent injury, and that loss of support is very hard for them. So we are trying to advocate for continued support for life for everybody by providing guidance, support, education, and also a community for people that we work with well past the end of the case. Just some of our results recently in 2025, we were able to secure 18 million in settlements for traumatic brain injury clients. Many of them were with co-counsel law firms. We were able to receive a $7,250,000 settlement in a carbon monoxide case, and we have had multiple 7-figure policy limit cases. We truly, to our core, believe that when someone has suffered from concussive symptoms, it is potentially permanent in nature. And when something is permanent in nature, there is no amount of policy limits that is enough. And so that's why we say policy limits are never a barrier to us, never. So I want to talk a little bit about the brain and how we can distill what is perceived as the most complex subject, right, neurology and neuroscience, down to its basic form so that we can truly educate a jury and adjusters. We choose an 8-year-old to be the target of which our communication needs to flow through. So if an 8-year-old is able to understand what we're articulating, then we feel assured that anybody on a jury panel or the adjuster that we're speaking to is going to understand. So that is my goal, is to speak to you in this TBI Masterclass as if you were an 8-year-old and to really distill this information very simply. So just to start off, we have 100 billion neurons in the brain. What is a neuron? It's basically a means of transporting information from the brain to the body and the body to the brain. Think of neurons like cars on a highway. They are transporting something. Cars transport people, neurons transport information. And these neurons flow through what's called a fiber track. A fiber track is basically like a telephone wire. Another analogy is a garden hose, or another analogy is a highway. Whatever you choose, it is the way in which these neurons are actually flowing from our brain to our body and our body to the brain. So they're very important. Without the highways, cars wouldn't be able to transport people, right? Without telephone wires, we wouldn't be able to communicate. Without a garden hose, we wouldn't be able to transport water. So think of fiber tracks as that mechanism. And any one of those three analogies have been utilized by us in conversations and in litigation. All right, so let's talk about how we actually sustain a brain injury. There's two main ways. One is sustaining a focal injury at a site of impact. That's essentially when you're hitting your head on the steering wheel or against a headrest. That is a direct contact to a particular part of the body. The most common mechanism of harm, though, happens when there's no direct impact. And that happens when your brain, floating in cerebral fluid, knocks against your skull. That's called coup contre coup. So if we wanted some imagery, I want you to imagine a mason jar full of water, and we put a tennis ball in there and we shake it up. That's essentially our brain floating in cerebral fluid and how easy it is to knock against the skull. So when someone says, oh, there was no impact, there was. The brain knocked against the skull. That is impact. So you absolutely can have a case where I hit my head against a steering wheel, which knocks me back, which then knocks me forward, and we essentially have two impacts: the focal injury and then the brain shaking, coup contre coup, two separate injuries. And what's really important is, so you can have two types of injuries, called a focal injury and a diffuse injury. And then the symptoms that come are very reliable and predictable in every case. Usually everyone experiences what's called a primary injury when we have that focal or diffuse impact. So the primary injury is that nausea, that feeling of dizziness, disorientation, feeling out of it. A lot of people are nonsensical on scene, temporary loss of consciousness. That is the primary injury that we're experiencing upon impact. Then we start to experience secondary injury, brain injury, over the course of about 2 weeks. That's why in most high schools, if you have a suspected concussion, there's a 2-week concussion protocol where you're not allowed to play sports for 2 weeks. That is a reason. It's based on the notion that secondary symptoms will happen over the next course of 2 weeks. And that's where we get essentially your brain reacting to the trauma and the subsequent impacts to it. So when you have trauma to your brain, there's a lot going on. We have inflammation, cell receptors are dysfunctioning. We have chemical changes in the brain, less oxygen, less blood flow, and that's where we're now going to see the symptoms that are coming about from that. For most people, they go to an ER or urgent care upon the primary brain injury. So they are experiencing a limited amount of symptoms when they go, and the ER urgent care is potentially saying that doesn't seem significant enough or to diagnose you with anything. They let you out and discharge you without really a diagnosis, and then the secondary injury symptoms then kind of windfall from there. And so that's why most of this is missed at the EMS, ER, and urgent care level. So what does happen at the initial EMS, ER, urgent care level? Well, emergency medical staff is typically trained to do a Glasgow Coma Scale analysis. Now, we hate this test. The Glasgow Coma Scale was created in 1988, and essentially it is a 1 to 15 quick triage that was used in battlefields to determine if somebody sustained a brain injury and needed to be triaged in one sense of the way or another. We still use it even in the clinical sense, and it is ridiculous as a marker of a brain injury. Why? Because if you are able to you are able to be verbal in any manner and you have motor skills, you're going to get a 15 out of 15. You can have a brain injury and be able to open your eyes, be verbal, and have motor skills. So this is not a good indication whatsoever. Most people you will encounter with a brain injury, an objective, true brain injury that has been documented and we've proven in our cases, had a 15 out of 15, which means a perfect score when they saw EMS. So really, this is only a good indicator if it is severe, if you are unconscious on scene, right? If you are not verbal, not able to open your eyes, no motor function. So this is in a very serious case, this would be appropriate, but any other cases, this has 0 markings. It's very easy for the defense to rely on this and to note you have 15 out of 15, they can't possibly have a brain injury, and we can disprove that just by the very nature of explaining what this is and how ridiculous this is to be a standard still used today. Most brain injury victims can lose consciousness, literally be seen by their passenger as out of it, lost consciousness, come to, EMS arrives on scene, and because they come to, are able to, again, have eye movement, verbal, and motor skills, 15 out of 15, even though they lost consciousness and a witness saw it. So again, this is used in nearly every case by EMS, ER, in some urgent cares, and it's important to know and be able to debunk it. So we've talked largely about how brain injury cases are not detected by EMS and ER staff. They're using the Glasgow Coma Scale. And we also talked about how that primary symptoms may not be severe enough that they're notating anything, but the secondary symptoms to come are going to be substantial. If they do suspect something, they will run tests. They'll likely do a brain MRI or CT scan, but even that is not going to be able to detect a brain injury, and I'll explain why. So a MRI and a CT scan, that is going to measure anatomical changes to the brain, anatomical meaning structure. So of course, if you have a skull fracture or a subdural hematoma or internal bleeding, it may show up, but it's not going to show that physiological change. And that's where we're talking about that secondary symptoms, right? We have inflammation, cell receptor damage. We have decreased oxygen, decreased blood flow going to the brain. All that can be happening and nothing is going to be on an MRI or CT scan. And that's why a dead person would have a normal MRI and a CT scan, because it's not showing that the brain is dead, which is physiological. Everything structurally would be intact. So that's why, again, these two tests are just critically at its highest level trying to see very severe cases. And again, anybody that is less than a very severe case initially is going to fall through the cracks. All right. Well, the problem that happens is you're basically told by EMS, ER, urgent care that you're fine, you're discharged, or given no medication, no diagnosis, and not told anything about follow through. And also your primary care, even if you follow up with them, may not be attuned to ask the proper question. So basically you're getting no validation to the symptoms you're having as being part of a brain injury. So many times our law firm is the first to catch these things and actually talk about them. And so we're going to talk about what it's like when a client comes into our firm and how we support them and how we prove their case. So just a quote that's important for us: there is no value you can place on permanent damage to your brain. which is the source of your information processing, your identity, even your soul. So why do lawyers ask for anything less than policy limits or more? And this is really important for us. We truly believe that even the most minor of concussive symptoms can be permanent in nature and are deserving of whatever policy is out there. And so we want to talk about kind of the steps we take to be able to do that. And so there's really 5 main ways that we can prove a brain injury case. And we'll go through each. But the first one is positive objective test results. Second, CPT code diagnoses. Then a history of reported concussive symptoms throughout the medical records, right? Even if you see a podiatrist, you're talking about your concussive symptoms. Then we talk to before and after witnesses that talk about who they were before and after and the impact these symptoms have had in their life. And lastly, it's cut off on this picture, but it's the client's own testimony about what they've been through. So let's start at the beginning. Objective tests. This is crucial. I can't tell you how many times I've heard that a brain injury is an invisible injury. It is not. It is objective as can be. It's more objective than most injuries, actually. And so it's really important to understand what symptoms somebody has and what test is actually out there to objectively prove it exists. Now, what's really interesting about being a brain injury attorney is that I can take every single test my client will take. Unlike if a client was to have an orthopedic fusion surgery on their back, I can't go electively take that to understand their experience. But I certainly can take all of these tests, and I have. And that's really important to understand what the test is, how to explain it to the client, and also how to understand how it is operated and what the results show. So I highly recommend going and connecting with a provider that does this test and simply ask if you can take the test and get educated on the process. They would love to do that, I assure you. Okay, so step 1, what you want to do is we're going to talk about the categories of symptoms. And out of the categories, what symptoms we see, what test is associated with that and is objective proof, and then when you should get those tests. Okay, so let's start with vestibular symptoms. That's your first bucket of symptoms. Vestibular symptoms basically means that you are suffering from imbalance because your ears, your eyes, and your brain are no longer talking to each other. When that happens, you have dizziness, disorientation, vertigo. And so that is a test that is objective as day, and it's called video nystagmography, or VNG. And you need to have the client take that, or you need to take it when you are symptomatic. So if a client is experiencing dizziness, disorientation, and vertigo, you would take that test and you would be positive. If they had dizziness, disorientation, and vertigo 2 years ago, and that symptom has kind of waned, and they're not really symptomatic anymore, it may not be. So this is important to take when they are still symptomatic. So the VNG is basically a set of goggles that you wear, and it tests how the brain, the eyes, and the ears speak to each other, resulting in what's called nystagmus. Nystagmus is the flickering of the eye. Now, we see that when someone is doing a BAC test, when someone is suspected of being drunk, and the cop will say, follow my finger, they're looking for nystagmus, or that flickering, because that delayed response when you're intoxicated is similar to what a lot of our clients are experiencing every day. Doesn't that seem pretty significant? So that's vestibular symptoms. So that's your first bucket. That is the client suffering from dizziness, disorientation, vertigo. Then that's the VNG test, and it's taken when they're symptomatic. The next one is cognitive. That's the next bucket of symptoms. And a lot of clients experience this with that secondary wave, and this can continue for years on end. And this is that brain fog, memory issues, persistent headaches, inability to concentrate. This is truly showing that the path, the neuron of information is trying to take from the brain to the body and the body to brain. It's not going anywhere. And we'll explain more about this, but that test is called diffuse tensor imaging. And you should take that at about the 6 to 9 month marker, because that's really going to show, we talked about that secondary symptoms are starting at about 2 weeks. Well, at about 6 to 9 months, your brain has taken a radical transformation with regards to chemical cascade changes, the impact of decreased oxygen, decreased blood flow, everything that's happened. And about 6 to 9 months, we're really starting to see the permanent impact. The next category of symptoms is autonomic. Autonomic is those major organ dysfunctions. So your brain is the power center of the body, and if the brain is on the fritz, then the different major organs we have are naturally going to be on the fritz as well. So it's not uncommon after someone sustains a brain injury for several things to happen where they initially think it's unrelated, and most people think it's unrelated, but we're attuned to autonomic dysfunction. And so it's very common for people to have respiratory issues. They can't regulate their body temperature. A lot of people have chest pain. They think that they go to the hospital thinking they're having a heart attack, but they don't tell anybody because they don't think it's associated with this case. Men tend to get erectile dysfunction. Women get a loss of period because of the reproductive organs, a lot of hormonal changes. This is all directly related to a brain injury. And the test for that is called a tilt table test. You can see it on the imagery here. They are strapped up on a table, and the table basically increases to different degrees over a period of time, basically testing your body's ability to regulate itself. And again, you're going to do that when you're symptomatic. So we've had clients that have lost their period over a course of a year. They took a tilt table test. It was positive. So we want to see what are the dysfunctions they're having, and is this a good test to take? There are other tests. I mean, it's endless what tests are out there, but if you're having vision issues, there are numerous tests that you can get, new products coming out. You might have heard of the right eye or the eye box test. Basically, it's showing your eye's ability to fixate on a target, and it's going to help see where your vision and your ability to focus is off. And also with hearing tinnitus, there are tests that you can get to objectively show a loss of hearing or tinnitus in the ear. So we are big proponents that brain injuries are not invisible, that they are objective, very objective, and that it's important to get those objective tests. Before you ask, I always get this question. We only get neuropsych examinations if the defense requests one in a IME or independent medical examination. So let me explain why. So Dorothy Clay Sims, the author of Exposing the Deceptive Defense Doctor, argues that neuropsychological exams are often biased and lack scientific validity. Therefore, what we're trying to say is this is not an objective test. And here's why. There's a lot of misrepresentation in findings. The defense neuropsychologist may misrepresent what they find in scans, often leaving out favorable facts or findings that can support a plaintiff's case. The use of unreliable tests. The fake bad test, a test used by defense neuropsychologists, is controversial and has been found to be unreliable. Manipulation of data. They can manipulate data because, again, raw data is considered proprietary, and only thing that they're going to produce is their finalized report. So again, for all these reasons, we don't believe this is objective and therefore is not in our category that we discussed. And also what's really important is a neuropsych exam includes a very subjective portion where your client is interviewed about their mood and personality and their past trauma. So again, because of all these subjective components, we don't believe it's an objective test. That's why it was not on our previous slide. And here's a good example. So we had a TBI client subjected to an independent medical examination by a UIM or underinsured motorist carrier. What was surprising was we got the report back and it said that they failed 9 of the tests. So this is just a conversation we're having with our own neuropsych that we had to get to figure out what was going on. And essentially what we found was that when we requested the raw data, from this test, we found that it was inappropriately taken for several reasons. One being that our client was a high-level professional with extremely high IQ, and they were put in a cohort of just the average community. We found that the data was off in certain places. We just completely disproved it and then got policy limits. But it's just to say it is not an objective test. And if you ever get a neuropsych report back, no, it's not objective, it's likely wrong, and you should get your own neuropsych to kind of disprove it. So we do want to focus really on objective tests, and the best one is the DTI, or diffuse tensor imaging. So that's what I'm going to talk about today. So the diffuse tensor imaging, it tracks movement of water through the fiber tracts. That's what the test is, because if water can flow through a fiber tract, we know a neuron that carries information can flow through the fiber tract and get information where it needs to go. If the water can't flow through and it spews out like a garden hose, if there was punctures or kinks, then we know neurons or information are not flowing. And that would describe why we're having a slew of symptoms. And so this test is going to show how healthy is that fiber tract and is water flowing through it. So let's talk about the fiber tract and how it can be damaged. So a fiber tract, when we have a brain injury, is very delicate, and those fiber tracts can twist and shear. So you may see in a report or a neurologist talking that there is axonal shearing. The fiber tract has sheared and been damaged, or sheared and died. If a fiber tract, remember we talked about it could be analogous to a highway, a garden hose, a phone wire. If it is damaged or broken, information can't flow, and therefore we're going to have those symptoms. So DTI results. Here on our right, we have a normal brain, and we have the fiber tracts depicted here. It's beautiful. It looks like hair flowing. That's what a normal brain without a brain injury looks like. Our client had a DTI, and this was their result. We can see patches of those fiber tracts no longer able to have water flow. They are damaged and or dead. And so you can see what this looks like. Interesting a lot. This was a mild traumatic brain injury case with a 15 out of 15 Glasgow Coma scale at the ER, no diagnosis of even a concussion. Primary care did not diagnose anything. And we were the first to be attuned to potential brain injury based on the intake questions. And this is the result. It seems quite catastrophic, if you were to ask me, to lose so many fiber tracts, meaning just the same amount of information as they would normally have can no longer get through. Now you can understand why there are so many symptoms being experienced. Here's just another depiction of that. You have that control subject, someone without a brain injury, and you have that patient with the fiber tracts no longer able to function and dying. This is what it looks like in a report form. Is really what you're looking for is to see the amount of fiber tracts that were impacted. And so typically a test will bundle the fiber tracts and they will talk about how many bundles of the fiber tracts are impacted. So on this client, you can see there's abnormality involving 8 out of 33 measured white matter bundles. So essentially what it's saying is out of the client's bundles of fiber tracts, we're looking at essentially, a third to a fourth of them being impacted. This is astronomical because when we think about everybody perceives information in their given day by their 5 senses, we do it all day long. But someone that has now less fiber tracts has less ability to have that same amount of information flow to where it needs to go. And therefore, they are not getting the information processed as they should. And it's going to result in brain fog, memory issues, all of the things that we see. So this is very, very significant. And if it's someone that is young, it is incredibly significant because during the natural aging process, we all naturally get wear and tear to our fiber tracts. That's why someone that's in their 80s may not process information the same as a 20-year-old. But if we're already at this much of a deficit at a young age, imagine what life will be like them when they get to 80. They will have next to no ability to process information, which would require a full-time home care, which would then translate why they need an 8-figure resolution. And so it's really important to understand how many of the fiber tract bundles are impaired so you can tell the story of what they'll go through. Also important is just to really understand the different lobes of the brain and what those lobes of the brain do. So when we're talking about fiber tracts of the brain being damaged, well, fiber tracts send information from certain lobes of the brain to certain parts of the body. And so based on what bundles are impacted, we're going to start to see what symptoms are going to be natural. So this is a great graphic, and how we utilize it is essentially we've broken down all the lobes of all the main lobes of the brain in the symptoms that kind of correlate with those lobes. So imagine when we're doing an intake or throughout the course of treatment, asking the client and we're checking off different lobes of the brain that are impacted, you can really see how this is a diffuse injury. A diffuse meaning it spans the entire brain that was impacted. How has that happened? Well, remember putting the tennis ball in the mason jar full of water and shaking it? That's how you get this much impact throughout the course of the brain. We ask about symptoms constantly, regularly, literally every 30 days, constantly asking you about symptoms and the severity and how it's impacting their life. Because yes, by week 2, you're going to see those secondary symptoms, but as the brain continues to deal with dysfunction, new symptoms will happen. Some will wane, some will get progressively worse. There will be triggers that spark issues. So you really want to be attuned constantly to how they are being impacted. Another thing that's really important to know is people are not going to say clinical terminology for how they're feeling. So for instance, someone is not necessarily going to say, I have dizziness, disorientation, and vertigo, but they're going to say it in their own way. So they may say, when I go up the stairs, I need to clutch the railing. And that is their ability. That is how they're going to say I'm dizzy, right? They might say I feel woozy. They might say that when I stand up quick, it feels like the room's spinning. So you really just want to understand that people do not speak the clinical language that we are talking about today, and really start to understand how they're speaking, how they're discussing what they're doing. Normally it'll be a discussion of actions. So I have to clutch the railing when I go up the stairs. That is actions describing I have dizziness, disorientation, and vertigo. So really just being attuned to the way people are talking and trying to track what they're going through. Checking symptoms constantly is going to be the big thing. And so throughout the course of representation, you're gathering all the symptoms that they're experiencing. And we know that the symptoms are occurring because information is not flowing from the brain to the body in the body to the brain like they used to. And they're not flowing because there must be damage to the fiber tract, which is the way they need to flow. And we can understand if there's damage to the fiber tract by doing the DTI. So so that is how we show kind of objectively what's going on. And what's great is to bring in non-economic witnesses that can tell the story that before this wreck happened, they didn't have the symptoms and the flow of problems I just described. As for any symptoms, if you can find non-economic witnesses that can really talk about before and after, it is really pivotal. So I'm going to give two examples about how quality is much more important than quantity as for non-economic witnesses. So here's a good example from a real case we had. Our client was a cyclist and was hit by a car and sustained a brain injury. He had a neighbor, and our client did not know the neighbor's name, and the neighbor did not know our client's name. They simply lived next to each other and casually waved to each other maybe when they saw each other. The neighbor would be getting up at about 5 a.m. for work every day, would see my client in his funny bike shorts, put his bike in his car to go out cycling. And the neighbor would chuckle over coffee of, there goes funny bike short guy. And this was something that he would experience 5 days a week for several years. And then one day he never saw my client's funny bike shorts ever again. And so that's just it was about 1 to 2 minutes of testimony, but very impactful. Another good example is a client that was very personable and charming, and he was older and would spend his time going to Starbucks early in the morning and having banter with the baristas. He would always order the same thing, make funny jokes, and always pay in correct change cash. After the wreck, he was very quiet, fumbled over the order, and fumbled over how he would then pay. Didn't know the barista's name. Barista didn't know his name, but when we asked, we were able to identify and get this testimony. So again, it's quality over quantity of just someone that's trying to tie those symptoms about how they didn't experience before, but they do now. Ask about symptoms often. We talked about that, and that's just all the symptoms. Really go through their daily life and talk about all the things that they're experiencing. It's really important that you're attuned to all the different, baskets, vestibular issues, cognitive issues, autonomic issues, emotional issues. So you're talking about all of those. Like I said, it's very usual for my female clients to lose their period, males to get erectile dysfunction. You wouldn't think to ask that, but we know about autonomic dysfunction. It's so common, so predictable, so regular that of course we're going to ask about it. Specialists involved in treatment of TBI, there's tons of specialists. And when you really think about how the brain is the power center of the body and the major organs, we have a lot of experts that you wouldn't think normally would be in a brain injury case. So it's not uncommon that we might have a pulmonologist to talk about the heart palpitations that our client's having from autonomic dysfunction, a urologist to talk about the consequences as well. And so we have a broad gamut of experts we're talking about that are conceivably unusual, but not when you think about when the brain is impacted, the entire body is impacted as well. So treatment is what's really important about treatment is to understand that these cases are not like most orthopedic cases. You can get objective proof of the brain injury very early, and you are able to get the results that we get at that point in time because we can understand and articulate what their path is. So there's not a lot of treatment sometimes in these particular cases because the treatment is merely going to allow for coping of the symptoms, and rather because we cannot repair or fix the core problem, which is the damaged fiber tracts. So when we can't fix the core problem, we can merely just make life better for them. That is really what our main therapists are going to help with, and which is critical. And so the therapists are going to translate with the symptoms we've talked about. So if you have vestibular symptoms, dizziness, disorientation, and vertigo, they're going to get the VNG we talked about, or video nystagmography, and they would go to a vestibular therapist. Cognitive issues, brain fog, memory issues, etc. That's that DTI, diffuse tensor imaging. 6 to 9 months, you would get that, and they're going to probably treat with a cognitive therapist. The speech language pathologists are usual as well, vision therapists, but really the therapist translates with the symptoms. Medication, note the medication they're being prescribed because sometimes it's really severe and it's really giving an idea of what is going on with the brain. It's not uncommon that people are being given seizure medications that are given to most people with epilepsy. They're given stimulants. They're given depressive medication. And so really understanding all of the scope of medication they're getting so you can understand what their life is and how the brain is that much on the fritz that the client essentially is taking seizure or epilepsy medication just to function in their daily life is quite significant. Why these cases matter? We truly believe that there's no such thing as a small TBI case. So when I was talking about the Glasgow Coma Scale or the MRI or the CT at the beginning of this training for severe cases, I'm more indicating that the primary injury or the initial display of the client is severe in nature, meaning that they have a fractured skull, a brain bleed, they are comatose. That is suggestive of it, but it doesn't mean that anything else is not severe in nature. So we do believe that anybody that has objective proof of brain injury is a permanent damage. There's no research that exists that you could that states that the fiber tracts of your brain will regenerate like your skin cells. They do not regenerate, they do not regrow. So it is a permanent injury. And it's a lifetime of injury. So as we said, this is permanent in nature. And as you age, you naturally get wear and tear of the fiber tracts. And so your ability to transmit information is going to dissolve. And it's very usual for people that are sustaining brain injuries to experience mood disorders, depression, PTSD, anxiety, excessive daytime sleeping, post-traumatic epilepsy. And think of the consequences of living a life like this. It results in lost or diminished wages, inability to take a job, ruined relationships, suicide. It's a very, very difficult life to lead. And one thing I feel no one is attuned to is imagine the life also of the caregiver. Let's not leave them out. The brain injury survivors are suffering so much, but caregivers are also survivors. So we want to know the life they're living and bring a claim of what's called loss of consortium for them, but not only have a claim for them, but also make sure that they feel empowered in getting the resources they need, because they also are living a very difficult life that they had asked for at no fault of their own. Large recoveries are possible in this case, and we've clearly shown that. So litigating, it is costly, it's time consuming, it's risky. Why? Because that's just general, yes. But if you are really looking at that pyramid, those 5 things, you can get more and more assured that it's not risky. You can be more and more assured that these cases are actually very repetitive and patterned, and you can systematically bring these cases. So the time consumption as you continue to do these cases decreases. And also, the costly nature of it will decrease because as you start realizing that there are certain providers that would make excellent witnesses, you have them early on in the treatment care as non-retained treating providers, and it also decreases them as being experts. So just the more and more that you do these types of cases, that risk decreases. What we always say is it's worth going for it if we have the objective test we already talked about, but we like the client, we trust the client, we're willing to take the case regardless of outcome. So litigation, we talked about that objective testing. We talked about the treating providers or experts that are going to tell the story. We talked about non-economic witnesses, and one thing we want to know is how to attack those defense experts. So the objective testing, we talked about it already. If you have a brain injury case, this is all new to you. You may be seeing a slew of MRI testing that has already been done potentially, but not any of the ones I recommended. That is completely fine. What you want to do is start finding all the tests that have been done, researching them, understanding what they do, understanding if it's good objective evidence, and we could tell the story, and also determining if we should get other tests. Those other tests are symptom dependent, right? Dizziness, disorientation is a BNG. Brain fog, cognitive issues, DTI. A brain scan is just a scan of the brain. And so we want to determine what additional tests that we talked about today will also be relevant to the test you maybe already have. So again, that BNG is so simple. It's non-invasive. If someone is having dizziness, disorientation, and vertigo, they should absolutely take this test. I've taken it myself. It's a pair of goggles that you put on your head. And again, you're tracking whether your eyes, your ears, and your brain are speaking to each other. And if they don't, then you have nystagmus of the eyes. And so there's 3 main tests. You watch a bouncing ball, and your eyes are following. You have a puff of typically water or cool air into your ears to see if your eyes, your ears, and your brain are talking to each other. And then you're also going to move your head up and down and side to side. That's it. It's a simple test. And this is actually my test, because remember, I take every test my clients take. So this is showing someone without a brain injury like myself and my ability to watch the bouncing ball without nystagmus. This is my client, right? And they have nystagmus, and their eyes cannot keep up with the bouncing ball, resulting in the flickering of the eye. At that, their defense expert stated that the VNG was not an objective proof, and it could have been faked, subject to what's called malingering or the client lying. After a series of questions to basically attack that and disprove it, we then got them to this point where they say, do you still agree that the VNG testing is objective testing that cannot be faked in any way? Where they say yes. Those providers, we talked about that there's so many associated with whatever symptom is happening, but at its core, you're going to have the neurologist. The neurologist is going to be able to talk about how the fiber tract damage is now not going to allow that neuron to flow. If the neuron can't flow, then there's information that you have through your five senses that can't get where it needs to get, and it's going to correspond with symptoms. And they will also be able to talk to you about if we have these symptoms, what our future care would be. Remember, dizziness, disorientation means you need a vestibular therapist. Cognitive issues, cognitive therapist. So they'll talk about the future treatment needs, and they'll also talk about the home care needs. So if you have these symptoms and they're permanent, what will happen to the brain, the high likelihood of developing dementia, Alzheimer's, and other complications, and the need for home, future home needs. So they can talk about all of those things. A neuroradiologist can talk about any of the radiology imaging that you're seeing and what it's showing. A life care planner can take what the neurologist is saying and put it in an itemized ledger about how much in current cost in the current market that would be. And then an economist can say, well, this is the current pricing, but if we're going to put that over the course of their life, say 40 years from now, this is what the cost would be then. And then, of course, there's more experts that can be needed based on your particular client. If it's a child case, and we do many child cases, we might have an educational consultant. If they are going to be impaired in their ability to work, which is very common, a vocational rehabilitation specialist is also normal. Non-economic witnesses, really when you're talking to them, you don't want to feed them questions. You just want to simply say, what were they like before and what were they like after? And again, it's the quality, not quantity. And the farther removed they are from familiar relations, the more credible they are. So we talked about banker, grocer, dry cleaner, barista. Most of our witnesses do not know our client's name. We have to go to the places our client interact and ask. Attacking defense experts. The main thing is just keeping them in their lane. So we talked about what a neurologist will know, which is the structure of the brain, how information flows, damage to the brain, and symptoms that correlate. Anything outside of that, they're not in their lane. So if they talk about the client's childhood trauma or their prior PTSD or depression as the cause of all of this, if they talk about any of that, they're not in their lane. And so it's really important that we note that, and we're really trying to decide, are you trying to be a neuropsych right now or trying to be a neurologist? Where are you? Are you in your lane? It is predictable, reliable what the defenses will be in a case. So you already know how to defend them. There is not a single defense we've heard yet that is not defensible. Some of the very common ones were normal CT and MRI scans. We talked about that, how a dead person can have a normal CT and MRI scan. We talked about lack of identification TBI by EMS and ER. Didn't we already talk about that? Mild symptoms should have resolved within 3 months. Where did they get that from? There's actually no literature to say that's mild symptoms. And what's mild? Your inability to concentrate, dizziness. What is mild? Right? And there's no information suggestive of when appropriately it should wane. Am I supposed to magically wake up on June 13th and not have symptoms anymore? Where do they get this from? Pre-existing ADHD. ADHD involves chemical changes in the brain that can be remedied by medication. And so when we look at fiber tract and fiber tract damage, there's no literature that suggests that ADHD or marijuana use or anything like that can cause fiber tract damage. So they're talking about apples and we're talking about oranges. Also, it's really important to know that any kind of neuropsych testing that was done by their defense doctor, we have to make sure that they are looking at the right cohort. Was our client a high IQ or low IQ before? And are they testing to the right range? And again, a slew of, attacking that things can be faked or exaggerating and then disproving it that it's objective. So there hasn't been a defense we've seen yet that we can't overcome. Talking about a real case. So again, I said that this isn't a typical case where you have a certain amount of meds and you're trying to multiply it. When I hear that, I cringe, right? We're talking about permanent trauma to the brain, which is the source of our identity, our soul, and our ability to understand information. So there is no amount of money that is going to correlate with that. And this is a perfect case that I could start being able to articulate what so passionately was upsetting me when I would hear that people are trying to get a multiple. So we had a carbon monoxide case where a furnace was not installed properly, and a family was essentially poisoned for about 4 months with carbon monoxide. There was about 100,000 in meds, totaling some ER visits. Every time the alarm would go off, they'd go to the ER. They saw a neurologist. They had the DTI, the VNG, brain scans, and some cognitive therapy. And it was about 100,000. Well, we were able to get a $7,250,000 settlement. And before you say, well, that might have been because of the liability, it wasn't. The liability, even to this day, is very much disputed. It was really about talking about the permanency of the brain damage. So here's a quote from the neurologist. And I would be curious to know if you think I'm saying the same thing the neurologist says. Damage to the fiber tracts of the brain is permanent damage. Fiber tracts, unlike your skin cells, cannot regenerate. Once damaged, it is damaged forever. Half of Mrs. Moore's fiber tracts are damaged, correlating with her symptomology. As she ages, her remaining fiber tracts will denigrate, as they do with most aging people, but she will have next to nothing left. She risks early onset dementia and other devastating consequences. It is important that I speak like my neurologist speaks, and it's important that my neurologist speaks like I speak, which is speaking to an 8-year-old. And so really important that when you get a neurologist, you have to talk to them. You have to say, how would you explain this to a jury? And you have to make sure that they don't speak like they're trying to speak to defend their dissertation at Harvard. What they want to do is be able to talk about this as if it was to an 8-year-old, because they would be speaking to a jury. We had a forensic engineer in that case. Of course, it was still disputed, but the life care plan and the economist really had a $1.8 million life care plan based on 100,000 in meds, because again, she could have done endless therapies, cognitive therapies, vestibular therapies, but all it does is help you cope. It's never going to change the permanent nature of the injury. And so she didn't have to undergo a lot of those therapies for it to be clear as day what she was deserving of. So that's a real life case to explain how we utilized everything we just talked about here in that case. So if you want to add value to your brain injury case, of course, we want to talk. Give us a call or email us, and we would be happy to either train your staff on how to do these cases or do consulting work. We can practice nationwide, and we're happy to help. Let us know any way that we can get involved.